continue with section D. Moving along, we're at the trunk over here. We want to describe, we just explained the patient requires an arm trough for the upper extremity. For the trunk, this is if the patient has a neurological diagnosis and can qualify for contoured seating. We want to address it right here. This drop down here, comment, contoured back with swing weight lateral requires to maintain midline and decrease lean. So this is a contoured back with additional lateral supports that you can adjust to really bring the patient in. The second option here is contoured back required to maintain just a midline, not midline due to impaired trunk control. That is just the contoured back without the laterals. Sometimes a patient doesn't want to have the extra laterals. They don't necessarily need them. They're not leaning really to just have poor trunk control. So you can just go with the contoured back. Select that. Any additional comments that you may want. Patient sort of custom back, or if they have an obliquity, you want to discuss it. Let's go down to the pelvis. We'll bring it more over there. So let's discuss how the patient presents. We can put it in the comment section, but the drop down is a posture and pressure cushion required to provide pressure relief and stabilize pelvis. That's if it's giving the patient both combination for posture, meaning they have a neurological diagnosis, and the pressure, meaning they have impaired sensation or a history of skin breakdown or present cubitus. Pressure cushion requires to provide pressure relief. This would be for a patient who does not have neurological diagnosis to qualify for positioning, but they do have a justification for pressure. And then the last one is posture cushion requires. This patient does not have a justification for pressure, but does have a justification for posture. Now our patient is going to go with just the last one because this is a CVA with zero pressure issues. Strength. Again, it's red. We want to always bring down some sort of objective measurement for strength. Left hip, right hip, we give them a 3. If we want to put, let's say, lateral guides or anything like that, here's our drop down. Required swing away thigh guides to maintain lower extremities and neutral. These are our guides that go along the outside of the seat, along the seat pan, along the seat rail, and they kind of bring the legs together. The justification is to keep the position at midline, keep the pelvis at midline, also make sure that they're safe, they're not hitting their knees into anything. We can also add knee guides. So the drop down here requests swing away thigh guides. Again, swing away meaning you need to address the thigh guide and the bracket that attaches it. Medial thigh support is somebody is adducted and you want to abduct them. If their knees are tight against each other, we can put a medial thigh. So that where you press medial thigh, this patient we're going to go with the swing away. Any additional information we want to add, we can put in the comments. If you want to give them knee supports, specific seat belts and straps, anything that you can think of in the comment section, you can always add. Over here by the lower extremity, we have another comment box here also. Lower extremities requires foot box to maintain lower extremities on foot support due to limited strength and active range of motion. This patient would definitely benefit from a foot box as well. Now we're talking about the knee function. We can select limited, and the strength is going to be 0 if it's hemiplegia. This side we're going to do within function, but it is 3 over 5. Any comments we want to put about the legs, if they need specific, anything specific about the chair you want to add, put it in the comments. Neuromuscular. Now, over here, this patient requires power elevating leg rest to decrease lower extremity edema. This is actually part of the lower extremity, not the neuromuscular. If the patient has any lower extremity edema, swelling, we want to elevate their legs in order to make sure that we are able to increase circulation. Another justification for power elevating leg rests is that if a patient goes into recline and they're opening up their pelvis and they're kind of in supine, their seat will start sliding out of the seat. We need to make sure that we're elevating the leg rest to kind of make sure that their pelvis is not sliding forward. If you can picture a patient sitting in a chair or even yourself trying to lay back a little, automatically, unless you're accommodating the support on your lower extremities, you're going to start sliding in the seat if you're laying so far back. So the second justification here is patient power elevating is required to maintain lower extremity support while in recline, and that is a valid justification for Medicare. If you have a patient who you're able to justify the recline for, and now they do not have any swelling in their legs, they will still be justified and eligible for a power elevating center mount or individual legs. That would be a great comment. Sometimes you have a patient who can get their legs together and you want to Our patient can get their legs to the right, power, center mount. This describes the 1 foot plate in the middle that both feet can stay on. Some patients are unable to get their feet together and they require to have individual power elevating leg rest, the E10-10. This patient would go to E10. Whenever we can get them on a center mount, we'd rather go to a center mount. It keeps the chair footprint much smaller. It's easier to transfer on and off. It's less cumbersome. Always go power center mount when you can versus power elevating leg rest. Tone, if let's say this patient's hypotenacity, but if they had a proprioception, it's intact. Any comments about that we can include over here. There's also a justification if the patient would have hypertonic or spasms, we would be able to justify power recline to manage the spasms when they're in supine or to increase the active range of motion. So patient requires power recline to manage tone and maintain range of motion, or patient requires power recline to manage spasticity. Our specific patient here does not require either of them, so we're going to skip it. Wheelchair recommendations. We're going to have a bunch of different chairs here, some of the HD ones. Q500 is my go-to, or there will be X3. I'm going to go with the Q500. Q300 is basically the same as the Q500, just a little bit smaller, about an inch and a half narrower. So if a patient it's important to note that because the chair, the seat, and the motor are independent, meaning no matter how wide your seat is, the base doesn't get wider or narrower. So the benefit of the Q300, which is about 22 inches wide, you'll only get that benefit if your seat is 16 inches narrow. If the chair is already 18 inches wide, the difference between the Q300 and the Q500 in terms of narrowness, you're not going to get that benefit because the overall width of the seat will be just as wide as the Q500. TDX SP comes in heavy duty as well. Normal bill grade chair. Quantum, this is the HD. This means heavy duty for above 300. Merits is also a chair that makes group 2s and group 3s. So we're going to check the Q500. And the independent mobility with ADL care, cane walker, manual wheelchair, and scooter not appropriate. Patient is able to, again, we reiterate the same comment over and over and over. We're just trying to keep driving it home. Now, if the patient required heavy duty or very heavy duty, we would select over here. This patient not requiring. Accessories and modifications. So right now we know we want the base, and as you've seen in section E, depending on the seating system, defines the base. And now we have to go through all the accessories, even though we addressed a lot of them. We didn't go through the electronics and stuff like that. So this select power tilt, power recline, it's going to do a conditional logic, which must be edited. Power tilt and power recline combination to facilitate pressure relieving activities. Optimally redistribute weight with tilt to increase seating tolerance with frequent change in position. I want to do optimally redistribute weight with tilt and recline. Should actually write power recline. I've had Medicare say, oh, is that manual recline? That way with power tilt and power recline to increase seating tolerance. Tolerance with frequent change in position. Headrest with removable bracket, 5 posterior head support while on tilt, and recline. This patient's getting only a posture cushion. Posture cushion required to stabilize pelvis. We're not increasing pressure or pressure distribution we are getting. Providing pressure relief, we're not providing pressure relief. Let's take that out. Contour trap required to maintain with stability. Supports. Required to maintain trunk and midline and decrease length. Power elevating leg rest to maintain bilateral lower extremity support. Recline and to decrease edema. harnesses multiple actuators to operate and control multiple powered seat functions through a joystick. Batteries to power motors, swing-weight joystick mount for safe and ease of transfers. The above recommended wheelchair will provide the patient with independent mobility and will improve overall quality of life. Patients able and willing to operate a power wheelchair. We have some more options here. We can do the back and skin, pressure cushion, adjustable pressure. Let me scroll this down so you can see everything here. O2 holder. So some of these items you already could have addressed inside this box here. You can do them separately, whatever is your fancy. You also want to add power elevating seat to accommodate multiple height surfaces for MRADL care. Now we're going to go through their measurements. Top of shoulder means from the seat pan to the top of their shoulder. Axilla, seat depth, very important is seat depth. B is very important. Lower leg means from underneath the knee over here. This is lower leg. So A, you see it's all matched up. Top of shoulder should be B. B is top of shoulder, A is not here. C to the axilla. D is seat depth. E is lower leg, so you're going to go from underneath the knee till the heel. We want to know how long we need to go. And now again, if we put a 2-inch cushion in, if this number is, let's say, 17, we put a 2-inch cushion in, 2 inches when it's compressed, then we want to make sure we have our lower leg length is going to be 15 inches. That way he's square, foot is square on the foot plate, back of seat to the upper leg is square sitting on the seat, because if the knees are higher than the pelvis, you're not going to get full distribution. So you want to make sure you get these measurements pretty good. Seat to elbow, again, you're going to have, this is going to be from the bottom of his bum till his elbow, and then if we're going to be putting a seat cushion here, so the seat to elbow height on the order form is going to add another 1.5 inches, 2 inches. Hip width, very self-explanatory, the widest part of the hip. I would take the measurement from the front of the patient, not the back of the patient. It's just showing you what the hips are. Chest width, also front of the patient, and shoulder width. You can take that from the back of the patient. We go down here. This is my name. I'm the therapist. I write that I am let's say I'm an OT for argument's sake. Put my credentials in, and then I go ahead and I finish. Once I press finish, it is signed and it is sealed. I didn't fill something out here. So feeding, we said he is total dependent. And then we can finish it. And just like that, the evaluation is done. Now this was done in 2 segments, but technically this should be done once you're more comfortable, used to it, know how to navigate through this. This should be done with a therapist in 10 minutes. Thank you for watching. Any questions, you all have my email.